All right. Hello and welcome, everyone. My name is Meredith Shanda. I am the COO for MAVEN Project, and I want to take a moment to thank you all for joining us today. And thank you to our friends at Edward M. Kennedy for hosting today's session on insulin initiating and titrating in type 2 diabetes management with Dr. Kenneth Snow. And for those of you who have not met Dr. Snow, Dr. Kenneth Snow is a Chief Scientific Officer for Sequel MedTech, a maker of an automated insulin delivery device. Prior to that, he served as medical director at Insulet Corporation, a maker of insulin pumps, and as medical director for clinic strategy in the medical affairs division of CVS Health. Previously, Dr. Snow was on the staff of the Joslin Diabetes Center in Boston for 19 years, including 5 as chief of the adult diabetes section. In addition, he was also an assistant professor of clinical medicine at Harvard Medical School. So welcome, Dr. Snow. Thanks for sharing your expertise with us today, and I will turn it over to you.
Great, thank you. And it's a pleasure to be here, and thank you for everyone for joining me as we talk about initiating and titrating insulin in type 2 diabetes. So, disclosure, other than being an employee of a medical device company, as you heard, I have no other relevant disclosures. And the accreditation, as you've told, and this is my introduction about me, but you've heard enough about me. That's not why you're here. What you hear about is to learn about some insulin, and that's what we're going to talk about. And the goals for today, or at least the top 3 goals for me for today is to help you develop an approach to initiate and titrate insulin for patients with type 2 diabetes. Understanding the role and limitations of premixed insulins versus a basal bolus regimen, and also to provide some language examples to facilitate the insulin discussion. So to begin, just helping everybody get onto the same page regarding type 2 diabetes and what's going on. Type 2 diabetes is a progressive disease with ongoing loss of beta cells over the course of time. If you look here at the light blue line that is sloping downward, folks start off with a certain degree of beta cell function, and over the course of time, they lose beta cell function. Because of that, blood sugars begin to climb, and you see that down here, whether it's fasting or postprandial, and eventually they climb high enough that folks have a diagnosis of type 2 diabetes. That process continues over time, despite what the patient does, despite the therapies that they're on. And so frequently, folks do wind up needing insulin if they have type 2 diabetes for long enough. And there's an incredible delay in initiating insulin for folks who need it. There's multiple reasons for that. If we think about this from the doctor side of this or from the provider side of this, there's studies that show that insulin is often the therapy of last resort, and that A1Cs really climb well into the 9s. In one study, folks were uncontrolled for over 1.5 years before insulin got initiated. Why is this? Well, every physician knows that patients are reluctant to start insulin, and it's an iterative process with a very narrow therapeutic window, which means you start with a small dose and have to keep increasing the dose as needed. So it's an incredible amount of work to initiate somebody on insulin and get them to the right place. From the patient perspective, there's fear of injecting, there's fear of complications, and many, many more that I'm not going to get into, because anyone who's ever had the insulin conversation with a patient knows there's lots of reasons why patients do not want to start insulin therapy, despite it being necessary for so many. And so as we talk about insulin management in primary care, number 1, pick your insulin. So you need a long-acting basal insulin that you're going to choose, and we'll talk a little bit about that in a minute. Pick a starting dose. I tend to like 0.2 units per kilo. Why? Because it's easy to remember, and it works. And I'll show some of the data behind that. And then prepare to titrate. And when I say that, I mean, tell the patient this is the starting dose and set that expectation. This is one of the few drugs that you titrate for patients. And as such, it's a unique experience for them. If you think about how we start off with antibiotics, we don't start with a little dose of antibiotics. And if their pneumonia is not cured, we increase the dose of antibiotics. We start off with a therapeutic dose. But for insulin, obviously, that's not true given the narrow therapeutic window and wanting to be safe and not induce hypoglycemia. So we want to make sure the patient understands that that first dose is probably not going to be the right dose. And so they're expecting the dose to increase. Have an algorithm available. I think this makes it much easier to know what your next step is going to be rather than having to create the wheel for every single patient. And then consider patient-driven adjustments for the right patient. You can give them criteria and the guardrails under which they can adjust their insulin themselves. First of all, this puts the patient in charge and it gives them much more reason to be engaged in their care. And second of all, not inconsequentially, it takes a little bit of the work off of you. So it makes your life a little easier and it makes them more engaged. So for the right patient who is willing and able to engage in their own adjustment, it's something to consider. So as I said, set a goal. You want to know where you're headed. So this is not the just initiate insulin, let's see where it gets you. You want to know, are you shooting for an A1C under 7? Are you shooting for an A1C in the 7s? What is your goal for this patient? What are you trying to achieve? You may or may not be able to achieve it for them, but ideally, what are you aiming for? Expect multiple titrations, as mentioned, and adjustments should not be faster than every few days. You want to give the insulin time to come to equilibrium. And a lack of efficacy can contribute to non-persistence. And what do I mean by that? Well, if you think about it, from the patient perspective, they get started on the insulin and they're getting started on a relatively low dose, a starting dose. And this is likely to be not therapeutic. It's not going to bring their blood sugars in line. And so if they have an A1C of 8.5 or 9 or higher, and they're running blood sugars of 200s and they start injecting, what they're going to notice is that their blood sugars in the first week are probably not much better. If you don't titrate them on a relatively regular basis that's relatively quick, at some point, they're going to become convinced that insulin doesn't work or doesn't work for them or isn't helping them. So if the adjustment is every 3 months, that's not going to work because after month 1 and after month 2, and their blood sugars are still elevated, why should they continue to take it? And so it's easy to understand why they may not be persistent in taking their insulin, because from their perspective, it's not working. So while you don't want to adjust too quickly, as in daily, neither do you want to adjust too slowly, because that lack of efficacy that they see can contribute to them stopping the drug. So I'm going to show data on 3 different algorithms and some of the supporting evidence behind them. And the first one comes from ACE guidelines. And this is based on adjusting every 2 to 3 days. And it's based on either a fixed amount of insulin or a percentage adjustment, depending on what they're on. My own bias, I like the percentage adjustment a little better because you get to where you want to get going, the way you want to go a little bit faster. There's what's the starting A1C? If it's less than 8, you can start as a total daily dose to begin with, 0.1 to 0.2. If they're over 8, you can use 0.2 to 0.3 because they're higher. That's why I like the 0.2, by the way. It's right in the middle of this, and so I like remembering only one number. And also, it's unlikely that you're starting insulin if their A1C is under 8, given all the other options that are available now to them. And so 0.2 is going to work fine for them, but if they're up over 8, you want to start with 0.3, that's fine too. And then initiate the insulin, titrate every 2 to 3 days to reach their glycemic goal. And you can either do a fixed adjustment, just keep adding 2 units every few days, or what I prefer is adjust based on how high their blood sugar is. If they're fastings, and have them check fasting every day and take the average. And if their fastings are over 180, then add 20% to whatever they're taking. and we'll run through this a bit later. If they're between 140 and 180, add 10%. And if they're getting close, 110 to 139, add 1 unit. And if they're hypoglycemic, if you overshoot, well, if they're under 70, cut back by 10 to 20%. If they have a very low blood sugar, cut back more, 20 to 40%. And this regimen will get them there relatively quickly. A second algorithm that's available comes from the Treat to Target trial. And this was based on weekly self-adjustments, actually. So you can either use this algorithm for you. You can certainly, for the right patient, again, you could have them self-adjusting at home. And roughly, it would 12 weeks. Also, the way to look at that is 12 adjustments were required to optimize the dose. And if you're looking at the graph all the way to the left here, this is what happens with the A1C over time. And if it looks like there's 2 lines there, it's because there are. And one is done using glargine, and the other was done using NPH. And these lines are almost superimposed on each other. And the reason is that they're both highly effective, and other insulins are effective as well. So there is not much difference in terms of efficacy at lowering blood sugar between different basal insulins that are out there. They all work. And so if you think about choosing an insulin, choose one that is readily available to the patient, one you're comfortable using, one that may be less expensive for them, that's covered by the insurance. There's some differences regarding hypoglycemia, and we'll talk about that, but the major deal is getting something started for them that they're going to continue. And the algorithm was based on a study that said start with 10 units a day, so they didn't even start at the 0.2, they started a little less, they started just at 10, which is another way to approach this. And then if their blood sugars were over 180 on average, add 8 units. 140 to 180, add 6. 120 to 140, add 4. And if they're between 100 and 120, add 2 units. And so one of the reasons I like this is because if they're really running high when you start them and they're up over 180, rather than starting them at 2 units or 10%, which if they started on, 10 units a day, it might be 1 unit, or if they started at 20 units a day, it might be 2 units. If they're really running high, this gives them a good increase early on to try to get those blood sugars down a little faster. Not so much because there's any rush, but more importantly, because they will begin to see improvements in their blood sugars and realize that the insulin is working for them. And then the third algorithm I wanted to discuss comes from the Titrate study. And folks are randomly assigned to one of 2 goals in that study. There was a tighter goal and a looser goal. And for the most part, we're going to talk about the looser goal here, which they're shooting for fasting blood glucoses between 80 and 110, also known as 4.4 to 6.1 millimolar. But 80 to 110, which for most patients is going to be more than adequate. If we look at the graph on the right, you can see that group, that's the boxes, they were able to achieve, and by week 12, an A1C of essentially 7, and actually drifted down a little bit further to just under 7 by 20 weeks. So you're really able to achieve what you want to achieve for most patients with that kind of target. And the algorithm itself in the upper right is pretty straightforward, pretty simple. If they're above targets, or if they're above the 80 to 110 range, add 3 units. If they drop below it, cut back by 3 units. If they're in the target range, do nothing. This is a great algorithm, not only to be able to use by a provider, but it's also, again, an algorithm that many patients will be able to follow at home. So you have them check their blood sugars at home, take the average of their fastings, and if they're averaging over target, just tell them increase your dose by 3 units. And they can do that once or twice a week. And so here are the 3 laid out together. The ACE, the titrate, and the treat to target. And it's less important which algorithm you use. other than it's one that you feel comfortable with, that you have readily available to you. And if you are going to be having the patient self-titrate, I wouldn't recommend asking them to be doing 20% of their total daily dose. It's just a disaster waiting to happen. So it's a lot easier to be able to give them a card that says increase by 3 units every day, or increase by, if you want to be a little more sophisticated, depending on what your blood sugar is, increase by anywhere between 2 and 8 units. Those are easier for patients to follow. So I'd like to switch gears for a second and get into a little bit into the language of insulin. And this is not so much for folks to quote or to memorize, but to try to help provide some language that reassures the patient that what they're doing is the right decision. What we don't want to be doing is threatening patients. You need to go on insulin, otherwise you're going to go blind. We don't want to threaten them because we know it doesn't work. Patients don't respond well to that. And there's a lot of self-blame that goes on this. And among patients, there's a lot of blame that other people put on them. And so making them feel better about this type of therapy makes them more likely to engage, makes them more likely to persist in the therapy, makes them more likely to be successful. So one of the first things is just they're blaming themselves. And so you want to reiterate what we led off with, which was that diabetes is a progressive problem. So if folks have diabetes long enough, there's a good chance they need insulin, not because of what they've done, but because of what their pancreas has done. And so I like your body's not making as much insulin as it used to. That happens to people with diabetes. Let's switch the blame off of them and kind of blame the pancreas for not doing its job, because that is the truth. They're worried about insulin as a medication, as a drug, and their side effects. Insulin is natural. I always like every critter walking around makes insulin. It's true. It makes them reassured this is not, something that's going to be strange. Insulin's safe. It's not a new drug. It's been used for over 100 years now. There's not going to be any big surprises with this drug. Now, we know that there's been some modification, so it's not exactly what was first used in 1922, but from a patient experience, insulin is not a new drug. So let them know that. Insulin does not cause complications. Many of your patients are going to be convinced that insulin causes complications. And the reason is because they have experienced it. They've seen it in friends and relatives. They all have Cousin Bill or Uncle Joe or their friend Nancy who had type 2 diabetes, finally got on insulin, and then they had fill in the blank of horrible complication, an amputation, a heart attack, went blind, whatever it may be. And these are true stories. But obviously we know that it's not because of the insulin causing the complication. It was because they were too slow to initiate on therapy, ran poor control for all those years, and developed those complications. So make sure your patient understands that, because that's not the relationship that they necessarily are thinking about. So some people wait too long before they get started on insulin. That's not healthy. We're not going to let that happen to you. We're starting insulin now before you have those events, so you never get to that point. Many folks are frightened, they say, oh, I'm going to have to do an injection. They're frightened of needles. I had an insulin pen on my desk with a 4-millimeter pen tip on it, or you can do that, or have a 5/16, syringe that you just show them. Remember that your patient's experience with needles are either blood drawing or flu shots, and neither one of those is fun, and neither one of those is painless, and neither one of those is a 32 gauge needle. So their experience, when you say needle, is very different than what they're going to experience with an insulin injection. And so I would have one on my desk and I'd hold it up. And since many of these folks are, over 40 or over 45, like myself, they're farsighted. and they need reading glasses, and you haven't warned them ahead of time, so they're not wearing their reading glasses. And if you hand them the pen, what they're all going to do is pick up the pen and do this to it to try to see the needle. And as soon as they do that, they appreciate how small this is. And you just look at them and say, yeah, that's it. It's just, you've had splinters bigger than that. Insulin's painless. Let's do the first dose right now. If you are blessed to have samples around, if you have a sample pen that you can give them the first injection right then. 2 units. For somebody needing insulin, A1C well into the 8s or over, certainly over 9, 2 units of glargine is not going to get them hypoglycemic on the way home. So you can do that first dose in the office. And many times I would have them do the injection, show them the technique, and hold their hand literally as they were holding the insulin pen and injecting. Nothing reassures them better, and I guarantee they're going to do that first injection. And I heard it so many times, they would just look up and say, that's it? And you say, yeah, that's it. Can you do that at home? And that is very reassuring for them. It's very reassuring to you because you know that they were able to do it. And all those fears of injection and pain goes away. As I mentioned before, make sure they understand about the starting dose and the need to titrate. Everyone responds differently. We're going to start with a really low dose and admit it, which is probably wrong. And we'll increase it till we get to the dose that's right for you. Now they're expecting that titration. So when you come back and up the dose and up the dose, or you talk to them over the phone, or they come in multiple times and have the dose adjusted, they don't begin to think, do you really know what you're doing, doc? Instead, they're like, yeah, this is exactly what you told me was going to happen, and that's exactly what we're doing. So they feel more confident in the process. And, oh, right, that's what you told me. We're going to adjust this dose many times because we want to be safe and get to the exact right dose for me. The need for titration will probably increase the dose about a dozen times. You're going to be probably right on most of that until we get to the right one. I expect you'll need around, and it's usually 0.6 to 0.8 units per kilo. So you can tell them. So if they weigh 100 kilos, tell them I'm expecting you to be somewhere around 60 to 80 units, because if you start them at 20, 60 can be a fair ways away. Most of the time you will be right. And then they will come back and say something such as, wow, doc, you're brilliant. You told me I would need like 70 units and that's what I'm on. Now, don't take too much credit because we all know, no, we're not really brilliant because of this. We've just read the literature. We know that that's right. If you come in that they're actually more sensitive and they need a lower dose, no one will ever complain. And if they're one of those insulin resistant folks who need upwards of, above 0.8, that they need upwards of 1.2 units per kilo, they will at least have noticed that their blood sugars are improved. They're not quite there yet. And then you can switch the conversation at that point to, oh, it looks like you need a little bit more for us to get to the right dose for you. And so they won't be bothered too much by this initial statement. So let them know where you're headed. So I'd like to present 3 case studies now. And the first, we're going to adjust based on the ACE guidelines. So 63-year-old man, type 2 diabetes, 16 years, currently on metformin, glipizide, and pagliflozin. A1C is 9.2. It was 8.9 a year ago. You wanted to start insulin then. He didn't want to start it. He said, oh, well, can I see what happens with him, until my next visit? And you let him go. He's promises he's going to follow his diet closer, even though his beta cells are gone, or many of his beta cells are gone. But you figure you want him to be ready. And he doesn't come back for whatever reason. And now it's a year later and his A1C is up to 9.2. He's 5'10". He's 237 pounds, which is 108 kilos. His BMI is 34, pretty typical size for somebody with type 2 diabetes. So you decide to initiate insulin. You pick NPH for whatever reason. We could have done this with glargine or levemir or whatever. You're starting at 0.2 units per kilo. He's nearly 110 kilos, so it's 22 units. And you're going to titrate based on the ACE guideline, which you could add just 2 units every single time, but you're actually going to adjust the regimen more aggressively, adding the 20% if they're up over 180 and 10% if closer, and 1 unit if it's getting really close. And so at the end of week 1, average fasting blood sugar 213. So you add 20%, which is 4 units to his current 22, and that moves him to 26, and he goes out for another week. And his blood sugars don't really change much because 26 units is not going to really cut it for this fellow. So he's still up over 180. He's now averaging 210 and probably not perceiving that that's any real difference. So he gets another 20%. Now, because he's on a little more insulin, 20% of the 26 is actually 5 units, so that moves him to 31. And now he's beginning to move, but still up there over 180. So another 20%, and that's 6 units and gets him 37. And finally, he drops below 180. He's at 174. So you're adding 10%, 4 units, 41, onward down here, down from by week 12, whereas average fasting blood sugars are 105. So you do nothing, and his new dose is now at 64 units. And so that's the kind of thing that you would see for somebody such as this. So let's do a second case here. And so looking from the treat to target algorithm, 63-year-old man, type 2 diabetes, 16 years, metformin, glipizide, empagliflozin. Yes, it's the same guy. A1C of 9.2, 108 kilos, initiate him at 0.2, 22 units. So this is all the same, but now the algorithm is a little different. So if he's up over 180, you're going to add 8 units, and that's where he is. He comes in at 213 at the end of a week. So you move him 8 units, so you move him from 22 to 30. And this gets him down to 190. And so you add another 8, and he moves to 38. And the next week he's 172. So you only add 6 and 44 and onward and downward. And by week 9, a little faster this time, he gets down to basically the same dose. He winds up at 66 with a average blood sugar of 98. So he's where you want him to be. And his dose is 66 units a day. Alternatively, use the algorithm from the titrate study. Again, same guy, you start him at 22. This is the algorithm that if it's high, add 3 units. If it's low, take away 3. And if you're in the right place, do nothing. So, and this person is going to self-titrate at home. And you may have them self-titrate once or twice and then check in. You may have them titrate several times. You may have them titrate until they hit target, depending on the nature of the patient and how comfortable you and they are with following this. So in week 1, starting off with 22 units, 213. So he adds 3 units to his dose, and he's going to do this twice a week. So every Sunday and Wednesday, he's going to titrate his insulin. So he checks, he adds 3 units, he's at 25. Obviously, that's nowhere close to where he needs to be, and he's still running high. Now he's 210, he adds another 3, and he does this twice a week, keeps adding 3 units, and by the end of 8 weeks, he gets down, and again, he gets into the same range, 64 units, with a good fasting blood sugar. So you wind up in the same place, not surprisingly. And it's just a matter of, for this fellow, while it was 8 weeks, it was 16 adjustments. So that's the way to get somebody on basal insulin and move them to where they want to be. But what about the person who needs to move beyond basal insulin? So maybe this is somebody already on basal insulin, was doing well and no longer doing well. Or maybe this is somebody who should have been on basal insulin years ago, never got started. Now you inherit him and you get him started on basal insulin. And what becomes clear is basal insulin by itself is not enough. So we'll talk about this now. About a third of folks with type 2 diabetes using insulin need mealtime insulin for glycemic control. Their beta cells have faded enough that they no longer have enough beta cell, despite non-insulin therapy, despite the SGLT2s and despite the GLP-1s or whatever else they're on, despite their other therapies, they no longer are able to control their postprandial blood glucose by itself. So they need more therapy than just basal insulin in terms of mealtime. And non-insulin therapy isn't cutting it. Now, success depends on choosing a regimen that the patient is likely to adhere to, which on one level sounds pretty obvious. Well, right, it won't work if they won't do it. But you'll see how that can influence decisions in a bit. Do not let excellent be the enemy of good, and we will definitely talk about what I mean by that. So some reasons to know it's time to move beyond basal insulin. Their A1C is elevated despite good fasting blood glucoses. So they adjust their basal, or they're on basal insulin, their fasting blood glucoses are good, but they're getting that A1C of 8.5. And you're convinced that those blood glucoses are legitimate, real readings. These are not just made up numbers in a logbook. They bring in their meter and it's running high. If they happen to be on a CGM, you'll actually see the pattern. It's likely that their blood glucose is high at some other time of day. It is usually post their largest meal of the day, which is usually supper time. And so they have this large supper, high blood sugars afterwards, and it takes them hours before their blood sugars come down. And so, yes, by morning, their blood sugars are down, but they have spent a good part of the night, 1/3 of the day, with elevated blood sugars. And so even though their fastings look good, their A1Cs are still high. Another indication, maybe they're wearing a CGM or maybe they're checking blood sugars before bed and in the morning. And what you see is this very large drop overnight. They go to bed at 450, they wake up at 120. Their fastings look great, but they're dropping 300 points overnight. So first of all, their A1C is still probably going to be higher than you want it to be. And second of all, if that person ever doesn't eat dinner, that is a great concern, because if they normally go to bed at 400 and they wake up at 100, if they don't eat dinner and they actually go to bed at 150, they'll get low during the night on that dose. So not only is it not healthy, it is dangerous. So that would be another reason to move on. And then another sort of sign of this, that it's time to move on, is despite being on a fairly large basal dose of insulin, they're not really achieving good control. So they're up over a unit per kilo, and they're still not getting where they want to be. This is possibly because they're high pre-bed with a large but inadequate drop, as we just talked about. It's possible that they're running high after each meal during the day, or that they're climbing after each meal. So they go up after breakfast, they go up further after lunch, they go up further after dinner. So they're never really getting to where they need to be. It is also possible that the patient is very insulin resistant and that they really need something that's going to hit them a little bit faster. So for whatever reason, these are sort of tip-offs that it's time to move beyond basal insulin. So there's a lot of ways to skin the cat when it comes to insulin. Probably the three most common is either the basal bolus regimen, a basal simplified bolus regimen, or using a premix. So basal bolus, folks are very familiar. It provides the best coverage and potential for control. No argument about that. The potential for control. But it does require 4 doses of insulin a day, 1 dose of basal and 1 dose of bolus insulin with each meal. And so it requires monitoring really 4 times a day, once with each meal and then once at bedtime. A great regimen in terms of flexibility, in terms of control, but it requires a lot of work. So if a patient is not going to do this much work, it is probably not going to work out well for them, because while this regimen followed is great, if they start skipping their doses, particularly their bolus doses pre-meal, and particularly if it happens to be before their larger meals, this regimen is not going to control them. So while people talk about basal bolus being the optimal regimen to achieve the best control, that's only true if they're willing to do it. So there's a basal and a simplified bolus, which is, again, basal insulin with a short-acting insulin at their largest meal of the day, which is usually supper time. And it achieves most of the benefit of the more intensive basal bolus regimen, but it's only 2 doses of insulin a day. And so it's only going to require monitoring 2 to 3 times a day. So this is less labor intensive, and we'll talk in a moment about, well, what am I giving up? How close to good control am I going to be able to get with this? And then there's premixes. So this is a mixture of short-acting insulin along with an intermediate-acting insulin. And so it is dosed before breakfast and before supper. The short-acting dose in the morning covers breakfast. The intermediate lasts through the afternoon and up to supper time. And then the supper time dose, the short covers the meal, and the intermediate covers overnight. But it is essentially NPH insulin that you're using, which has a peak about 8 hours later. And so while back in the treat to target trial, when they're giving it 11 o'clock at night to control fasting blood sugars by itself, NPH is fine. Now you're giving it before supper time mixed with short-acting insulin. And so now you run into a problem. And the problem is the morning dose can induce hypoglycemia before dinner, particularly if they eat dinner late. So if they have breakfast and take their insulin in the morning at 7 o'clock, but they're not eating dinner until 6 o'clock at night, well, that 7 a.m. intermediate insulin is going to be working in the middle of the afternoon, 3, 4 o'clock. They could get low then. And likewise, their NPH before supper that's mixed in, if they're eating at 6 o'clock, it's going to be working at 2, 3 o'clock in the morning when it peaks. So you will not be able to achieve a tight fasting blood glucose with them. If you increase the dose, they will just get low in the middle of the night. To decrease the dose so they don't get low in the middle of the night, they're going to wake up with not really high fastings, but not optimal fastings. So you can expect to get an A1C between about 7.5 and 8.5. That's where you'll wind up. You really can't get much better than that for most patients with a premix. Why do it? It's really simple. It's one type of insulin. You just do this breakfast and supper time. It's only 2 shots a day. They can't confuse their long and their short-acting insulin. It's just one kind. So it makes it as an insulin regimen pretty simple. One type of insulin, only 2 injections a day, not much more complex than a basal-only regimen. But the drawback is you're not going to get much better than 7.5 to 8.5. For the patient who's younger, healthier, and wants better control and is willing to do the work, not a great regimen. For somebody who is older, more issues, not able to do a more complex regimen, where their A1C's been 10, you'd be ecstatic if you could get them to 8. This is not a bad choice. To present one study, this is now getting to be about, this is about 10 years old now, but I think it's a very cute study. They looked at 588 people with type 2 diabetes with a baseline A1C of 9.4. So not too far off of what we're talking about with our imaginary patient in the case studies. And they divided this group, these folks up into 3 arms. One got a premix. It was Novolog premix. One group got glargine, and then 1 dose of bolus insulin with their largest meal. And the other group got your classic basal bolus glargine and 3 prandial injections. The study ran for 60 weeks. At the end of the study, there's no significant difference in total daily dose of insulin. There's no significant difference in weight gain. And the goal was to try to achieve an A1C of 7. And the data that I'm showing here, and we'll talk about in a sec, is looking at discontinuation rates, the hypoglycemia rates, and how their A1C do. And if you look at the premix, they had the highest discontinuation rate. Their A1C at 60 weeks was 7.2, which is pretty close to the other ones. But the hypoglycemia rate was really high, much higher, and probably contributes to the discontinuation rate. This is kind of an artifact of the way this study was set up. Remember, I had said that you really can't get much better than 7.5 with a premix. Well, they were shooting for 7. Well, to do that, you start increasing the dose and you start getting those hypoglycemic reactions either in the afternoon or overnight, as I mentioned. And so the way the study was set up, they had more hypoglycemia and more discontinuation. I suspect if they had cut back on the dose and let the A1C drift up to 7.5 to 8, somewhere in that range, they would have had a hypoglycemia rate that would have been on par with the other 2 arms of the study, but obviously would not have had an A1C that was on par. So we see with the premix group what we would expect to see. For the simplified bolus versus the more aggressive bolus, no significant difference in the discontinuation rate, 23 versus 20%. The A1C 7.1 or 7, hypoglycemia rate's about the same. And so you do have to ask yourself, well, you say, well, see, basal bolus better. So they got 7.0, the other group got 7.1. 7 is lower than 7.1. So clearly the 3 prandial doses a day was better. But I might argue that a lot of patients, if they had that data, would say, so let me get this straight. If I do 2 shots a day, I'm going to get to 7.1. And if I do 4, I'll get to 7. So I'm going to do 2 more shots a day to get another 0.1 off my A1C. Do I really need that 0.1? And I think a lot of patients would say, you know what, I'd rather do 2 shots a day and be 0.1% high. And obviously everyone's going to be different. There are some who are going to be more than that. They're going to have a larger difference. But it does get you thinking that for a lot of patients, the simplified bolus is going to work adequately for them, particularly if most of their calories come in from that 1 large meal a day. So consider that as a simplified regimen. And what that means is that if they're more likely to do that and stress the importance of that prandial dose rather than the 4 shots a day. If they're looking for optimal, doc, I want the best regimen possible. I don't mind the work. I don't mind the injections. They're younger. You're looking at a 35-year-old who's going on insulin and type 2, and you're hoping that there's multiple decades ahead of them. And so you want to keep them as healthy as possible. A reason to use the most aggressive regimen. But don't let excellent be the enemy of good, where you have to put everybody on a 4-shot-a-day regimen, and then they wind up skipping 2 of their shots every day. So in summary, insulin initiation is often delayed despite the recognized need. Having an algorithm facilitates the dose titration. Having an insulin initiation language as part of your vocabulary can ease the process for both you and your patient. And if advancing to a more complex regimen, consider the likelihood of adherence and the limitations of the regimens as you choose one for a particular patient. And with that, I'll say thank you for that and open up for questions and hopefully stop the sharing. And there we are.
Dr. Snow, that was wonderful. I really appreciated that personally. So, and we have some great questions already. So I will probably jump right into them. But as a reminder to everyone on the call, if you also have questions, feel free to drop them in the Q&A box. You'll see that at the bottom of your Zoom toolbar or in the chat if you prefer, or if you have a case you want to present or maybe ask Dr. Snow a question verbally, use the raise your hand feature and I'll see that on my end and I'll be able to unmute you and you'll be able to talk directly to Dr. Snow. So I'm going to jump right in because we got quite a few. If we don't have enough time, I'm sure we can figure out a way to maybe answer these and follow up via email, but jumping right in. The first question, you may have covered some of these, Dr. Snow, in your talk, but might be worth just reiterating some of them. So if you do a fixed regimen for basal insulin titration, what do you tell the patient their fasting goal should be?
Oh, if I can get them between 100 and 150 fasting, I'm happy with them. So, I'll tell them that that's where my goal for them is, and recognize that they may not hit it. You may not be able to get that 150. If they're a big supper eater and they eat early, you may not be able to even reach that level. So And you'll know that because, if they have a hypoglycemic event during the night, or you haven't checked blood sugars during, for a few nights during the night, and you see that they're getting a little too low during the night, you may not be able to hit that target, but that's where I aim for, is between 100 and 150.
Great. This next question is interesting. It's actually something I've heard about before. So this attendee said they've heard more about this over basalization issue, and they want to know if they should be doing short acting earlier, or if you have any comments on over basalization.
Yes and yes. Yeah, there is. It's understandable why folks get why there's this over basalization where you're just increasing the basal dose beyond really what they need. It's easy. It's easy for the provider, just increase the dose. It's easy for the patient. They already have one insulin, just take more of it. I mean, it's easy for everyone. It's easy. You don't have to fight the insurer with a second insulin. It's just easy. But the problem is you get into the situation, which is what I was mentioning, where you start seeing fastings may be okay because you push that basal insulin up, but they're running high for a good part of the day, or they're running high certainly overnight. So you're really not achieving the A1C that you want, and they're on a lot of basal insulin, and you're essentially using that basal insulin to try to cover mealtime problems. And that's not good for any number of reasons. It's not good for good control. It's not good if they have to skip a meal. We see this when people get hospitalized if they're over basaled because they get NPO for their procedure the next morning, or they're going for a colonoscopy or some procedure in the morning that they say, oh yeah, don't eat, don't eat dinner, and they happen to take their insulin because they're not on mealtime insulin, it's only basal insulin, and then they drop. So it's not good from a health point of view. It's not good from a safety point of view. And yes, it's definitely be on the eye out for folks being over basaled and moving them to some mealtime insulin sooner.
Great, thank you. All right, I'm jumping around, but I promise I'll try to get through as many questions as I can. This is an interesting one. So is type 2 diabetes reversible? If yes, is there a point of no return?
Yeah. Is it reversible? It's kind of a semantic issue, or a language issue. So if somebody with type 2, they don't have enough insulin production to cover the amount of insulin need. And that's essentially what it is. I can only make so much insulin at this point because basal cell loss, I need that much. I'm short, of a certain amount of insulin, and therefore I'm supplementing. Well, if you change the amount they need, they drop a significant amount of weight. They really get active, from exercise. Their need goes down, and their blood sugars may very well normalize. So, have you reversed it? Well, it's a kind of a semantic issue. You've matched up their supply and their need now, so their blood sugars look good. And I can think of some companies that argue in favor of aggressive lifestyle, aggressive weight loss, which is going to achieve this if patients can adhere. And their blood sugars will normalize, and may normalize enough that they no longer need therapy, any therapy, other than continued lifestyle management. Are they now cured? Well, I don't consider them really cured. They may have really good blood glucose control on their current lifestyle management, but if they go to McDonald's, or if they break their leg and they stop exercising, their blood sugars will go back up because the underlying physiology is still there. So I wouldn't minimize the value of this. It's extraordinarily wonderful when patients can do it, but I wouldn't necessarily say that it's reversed. And I know one company particularly that loves that term. I don't particularly like that term. What I'd rather say is that you've matched up their supply and their need right now. As for what will happen down the line, as best as we know, they will continue to lose beta cell function over time. So given long enough, they will then start needing more therapy than they're on. If they're on no oral agents, they will then at some point, despite all the lifestyle change and the weight loss, they will start needing something. And if it goes long enough, they'll start needing insulin. But again, it depends, this game has a limited clock on it. So if you're talking a 35-year-old where there's going to be a lot of game, we hope, ahead of them, they may wind up needing therapies, multiple therapies, insulin later on down the line. It may not be until they're, in their 50s or 60s, but, or 70s. If they happen to be 70 and they were looking at insulin and then go through, this aggressive lifestyle changes and they can get down to minimal therapy, well, the game will end for them, hopefully when they're 90s or 100 or whenever, and it won't go long enough that they'll get back to the point where they need therapy. So I don't know what you call it. Do we call it a cure? Do we call it a matchup that they no longer need additional therapy? Whatever you call it, it's good if they can do it.
Absolutely. I've never heard it described that way, so that's actually really helpful. This is in the same vein, so I'll ask this question. What slows down progression of diabetes?
There's conflicting evidence of, is this a standard part of the progression of the disease, or is there a bit of wearing out of the beta cell? And the difference would be if it's just simply a wearing out of the beta cell, the more you flog it, that it's basically getting tired. We think about it that way. So if it were all that, then losing weight, exercising would definitely help prolong beta cell activity. There's some evidence that that's true, but not completely. So it's probably, and there's an underlying component to loss of beta cells despite that. So just lifestyle is not going, or just losing weight, just exercising is not going to solve that, but it may be helpful. There's some evidence that certain medications, GLP-1s, for instance, may help slow the process. Note the word is slow, not stop the process. So it may be yet another reason why those agents are good agents for patients in addition to their ability to control blood glucose. But as far as we know, there's nothing that will arrest the process, but gets back to the weight management, exercise, and maybe GLP-1s, and maybe some other agents, as data comes out, will show that they slow the process.
Interesting. All right, here's a quick one. Should blood sugar be checked 1 hour or 2 hours after the start of a meal?
Yeah, I like 2 hours. There can be some foods that will send up blood glucose pretty quickly and then come down, particularly depending, a very high glycemic index food. And if we think about the, why you care about this, you care about, how long are basically proteins exposed to elevated glucose and hence are getting glycosylated. So probably one of the best ways to think about the damage getting done is it's not so much simply related to the height of the blood glucose that's achieved, but more related to the area under that curve. So obviously a higher peak is bad, but also for a longer period of time is bad, which also makes sense. And so if it goes up real high but comes down real quick, that's less bad than if it kind of goes up and stays up there for a much longer period of time. So I like looking at 2 hours because that gives you a better idea of where you are in terms of adequacy of whatever happened before the meal.
Great. All right, another question we have is the treat to target algorithm for initiating insulin does not mention hypoglycemic adjustments. So we're curious your recommendations there.
Oh, yeah, depending on, depending on the severity of the hypoglycemia. I like the 20-40 rule, 20% if it's down below 70, 40% if it's below 40. I mean, obviously this, you have to use you have to use a lot of clinical judgment in that, because why did it occur? If this is somebody who went through, the most incredible exercise regimen, they were on vacation and they took a 10-mile walk and they never do that. you're going to cut back a little bit less because obviously that's a one-time event, as opposed to, no, this happened in a much more routine part of their life, in which case you're going to be a little bit more aggressive cutting back because they're likely to do that again tomorrow. So, but I think of it in sort of the 20-40 range. 20% if it's a mild hypoglycemic event, they get down into the 60s, they got a little sweaty, shaky, versus if they had a significant event, down, let's say below 54, that it was a level 2 hypoglycemic event with or without significant symptoms. So
Great.
what you don't want to do is cutting it, by the way, by like, the value to that. What you don't want to do is be cutting which I've seen, the 50 or 70% off, because that's going to be way too much, and then they're going to be running high. And a lot of your good work of getting them where they needed to be now goes out the window. So you don't want to cut them too much. Obviously, and again, this is clinical judgment. If you're more concerned about that person, that they're older, they have more health conditions, the cardiac issues where you're much more worried about hypoglycemia, you may cut back a little more aggressively than if they're young, healthy, and it was a one-time event. So, use those numbers as sort of guidelines, but they don't usurp your clinical judgment.
Wonderful. All right, we have a case presentation I'm going to read to you. So
Oh,
this is exciting. So what should be done for a 50-year-old patient whose A1C is above goal at 9%, but basal lantus insulin at even low doses, like 16 units, causes hypoglycemia? This person's tried adding prandial Novolog at 3 to 5 units as well. But this is causing hypoglycemia while intermittent readings are in the 300s. Is it the type of basal or prandial insulin that this provider is using, or do you have any recommendations for this patient?
um, that's really unusual that they have so little beta cell function that they're running an A1C over 9, and yet they're so responsive to insulin with type 2 diabetes. And I guess I would start questioning. I mean, one of my questions would be, whether they really have type 2 diabetes, or whether this is, let's say, a type of MODY, where um, where genetic defect, and particularly MODY, I'm thinking about where they have an insulin secretory problem. So they're sensitive to insulin. You give them insulin, they get hypoglycemic. But when you take it away, they can't easily secrete their own. Those folks tend to do really, really well with sulfonylureas, weirdly enough. So that might be, and since sulfonylureas are often not used now for many folks, you have somebody where you think you're doing the right thing. Oh, I had them on metformin and an SGLT2 inhibitor, great regimen, but that doesn't work all that well for these MODYs with a secretory defect, and you put them on an old, glyburide, low dose, and they do extraordinarily well. So that'd be one of the things I would think about, is this really the right diagnosis? The next thing is technique. Has anyone seen them inject? Are they really injecting? You've told them what to inject. Are they really doing it, or they're pulling up improperly? They're mixing it up. They're putting an extra zero in there, and they legitimately think they're pulling up 3 units, but they're pulling up 30 units. We've seen that before. And if it's sort of none of the above, then then they're just somebody who's, they're behaving much more like a type 1. They may very well be a type 2, but they are very insulin sensitive with very little beta cell production. And either they're going to need very, very low doses of insulin. Think of them as like a very sensitive type 1, maybe, or like a kid, where they just require very little insulin. And that's folks, that's somebody who may very well require an AI, an automated insulin delivery device. I work for a company with it, so I don't want to, I don't want to appear biased, but that's a situation where they're just going to have a hard time doing that by injection. And a device that modulates for them might be better if they have the insurance coverage and you can get that through. That would be an off-label use of an AID in type 2, but because that's behaving much more like a type 1.
Great, thank you very much. Excuse me, I want to be respectful of your time, Dr. Snow, and I know we're at the bottom of the hour or top of the next hour. Do you have
Oh, we
any?
just hit Pi Day, so
I
it was
know we missed it.
314,159, so 3.14159. So happy Pi Day to everybody.
Do you have a few more minutes to stay on, or I can
I
send
have
you
a couple
questions?
more minutes,
Okay,
yes.
let's do maybe one or two more questions, and if anyone has
Thanks.
to jump off, you'll get the recording. And we appreciate everyone's time. But one question that I have here is, what is the risk of weight gain with the initiation of insulin, and what is the average weight gain?
Yeah. Um, there is definitely a risk of weight gain. It is usually way over blown in concern compared to what's seen in clinical trials. For most folks, you're talking a couple of kilos, so not a huge amount of weight gain. The one caveat that I put with that is, when you look at that in clinical trials, those tend to be folks who A1Cs are in the eights. They obviously have access to nutrition counseling and education, et cetera, and someone's looking at them. So they're not quite the worst case scenario. Where you get more of the, your worst case scenarios, the person who's, refused insulin, their A1C is now 10. They haven't seen a dietitian, and all of a sudden, and they've been peeing out, 500 calories a day of glucose because they have glycosuria, and you put them on insulin and the glycosuria stops. If they continue to eat the same, they can have significant weight gain. So those are the folks that I get more nervous about of having big weight gain, beyond what the studies say, and make sure that they understand that, hey, you've been on a great diet. It's really unhealthy, but you've been peeing out a lot of your calories. So if you continue to eat the same, that's not good. The one thing working in your benefit is those folks tend to be hungry because they're peeing out 500 calories a day. So if they know that, they won't have the same kind of hunger, and that they're more amenable to cutting back a little bit on calories. So hopefully they won't gain it. But those are the folks I worry about, the ones who have had significant glycosuria that you're going to, over the course of a few weeks, stop. And all of a sudden, if they continue to eat everything the same, that's 500 calories a day that they're going to be in excess.
Very interesting. And I wanted to follow up. We got a response about the last patient case that we were just talking about, and the provider says, you are right. The metformin and Jardiance was not working well for that 50-year-old patient, and they have started using CGM on them. So
yeah, so see what it looks like, and particularly see if they're running pretty good when fasting, so overnight, first thing in the morning, and whether they get these bumps postprandial, and that's the problem. And I know you tried to do that with you'd mentioned with prandial insulin, just a few units. That may be a tip off. And that they may do, if they happen to be a Modi, they might do well with um sulfonylurea at mealtime, or sulfonylurea, so they have insulin secretion at mealtime. So, which would be a cute little case to write up, by the way, if that turns out to be true. Um,
very interesting. Whoever that provider is, follow up with Dr. Snow on the Maven Project platform and let him know how the
Please let me know how it turns. Regardless of how it turns out, hopefully it turns out well for the patient. However it turns out, but however it turns out, whatever you learn, I'd be very curious. Um,
Wonderful. All right. Well, we'll end on that note. And I want to thank you for your time, Dr. Snow, and remind everybody to complete the survey that should pop up once you exit today's Zoom window. And if you do not get a chance to do that today, it will also be emailed to you in an email from Zoom tomorrow. So you can complete it using the link within the email. You'll also receive the slides from today, and today's recording will be published on the on-demand library in the Maven Project community portal. in about 1 to 2 weeks. So thank you for your time. If we weren't able to answer your questions today, I know we had tons of questions. Dr. Snow is available on the Maven Project platform, so you can send them to him that way, and I'm sure he'd be happy to help you out. So thank you again, Dr. Snow. Any last words?
Nope, no last words. Thank you all for joining today.
All right, take care, everyone.
Take care all.